So the talk after me is pretty much the same. So what we have decided is we'll touch on slightly different aspects of TAVR. So what I'm going to do is we'll take it step by step, and hopefully we'll get enough time we go through each procedural step and see how we can prevent complications. So probably the first thing we look at when we are doing TAVR is vascular access, especially in Pakistan when we don't have much in terms of alternative access. If there is no real access, we can't really do it. So vascular access is, and in all the initial TAVR trials, the main complication was actually in the vascular access. So we can have either narrow vessels, we can have a lot of tortuosity or calcium. So if there is, so this is just a case of very tortuous iliacs, which are pretty heavily calcified. So, and as we know with Medtronic and everything, that we are trying to minimize these vascular complications by using the inline sheath. So this is somebody trying to use the inline sheath because of all that tortuosity and stuff. This is our super stiff wire. We are trying to put the inline sheath in, and after we have done that dilatation, we can't really push the valve across this tortuosity. You can see the calcium on the iliacs. So for something like this, rather than trying to continuously do the same thing, we can go with a stiffer wire, and then we can actually put the actual sheath that comes with it. Obviously it comes with a bigger lumen, but it improves the procedural success rate. Then you have the calcified aortic arch. So again, arch has multiple dimensions. One, obviously, issue of complications is because of the calcium, but also you need to make sure that all this tortuosity it's in a 3D axis. And if you have a lot of tortuosity here, it's very hard to move such a heavy mass, metallic mass on a stiff wire even. So this is a case where you have done assessment of aortic root, and if you can see this, this should play. So what they're trying to do is actually here that they're trying to cross this calcified aortic arch, and they cannot. So what they did was they exchanged a more stiffer Linderquist wire, and they were able to do it. So again, all these things have to be at the back of your mind, that if you can't really cross it and you see a distance appearing between the nose cone, that means you are pushing your device to the limits, and the next thing is going to happen is it's going to break at the back. So you need to have a plan in your mind that if something like this happens, you go to a stiffer wire, and usually you are able to get around it. So again, for vascular access, you need to review the CT. I think people with whom I do TAVR everywhere, we always look at the CT before the case, no matter how much in detail and in depth we have seen it. We always make sure that while we are advancing the system, we are always doing it under fluoro. And then all these navigation challenges, we need to have a plan A, B, C ready when we are doing it. So next thing is Guidewire Management, and I think the last ever we did, Nadir Sahab was saying we need to be this comes with a lot more experience and stuff, because a lot of times either it goes really lax or you pull it too much, and you can sometimes even pull it out. And then probably one thing that we always miss out in all these preform wires is the tip. So we'll see one case. So it's a small ventricle, which you see in a lot of small women, hypertensive, small ladies with aortic stenosis, again causing even more left ventricular hypertrophy. So in this case, what is happening is, if you look at the wire, so this wire that we are looking at is a super stiff guide wire. Now we have these preform wires, but when we started it, I've been doing it since 2015. Then we did not have these preform wires. We used to make these shapes ourselves. And so obviously it's a man-made shape, and we used to do our best to make sure it's blunt at the bend. So what happens is that this part of the wire, you can see, do you have an arrow sort of a thing? No. So this part of the wire is pretty stiff, and then it turns into a much softer part. So there is this transition zone. So the bend should be just below the transition zone. So the soft part of the wire should be the one, just immediate soft part should be the one which is transitioning, and the hard bit should be just above it. So in this case, it's actually the hard bit which is poking into the ventricle. So here you can see in a bit more detail that this is the stiff part. The rounded nature of this bit has actually already deformed. So they have done the valve. They're doing the valve. Valve looks pretty good. And now, once they've done the aortogram, you can see this immediate halo, which is all that because of pericardial effusion. So you can, if you do not manage the wire, like obviously one thing is that it might even pop out of the ventricle while you're actually pushing the device up. But probably the most commonest implication of that is that you can end up with a pericardial effusion at the end. You might have done an amazing procedure, but a fully anticoagulated patient with a ventricular rupture, sometimes you might not be as lucky to get the patient off the table. So again, placement, we are shaping these wires, or we use the pre-shaped wires. Now we have the luxury of Confida, Safari and all those wires, where it's a pre-shaped wires, and these wires should retain their shape. Whereas when we used to make them, they would, even if you make a perfect curve on it, they would always tend to lose their shape. And then you always do it in RAO view, you maintain control of the wire at all times. Transition point should be just above the apex. It should not be poking into the apex. And the tip of the wire should always be pointing away from the ventricle. That's probably the easiest miss thing. We are always, in people who are pretty senior, they will always be looking at the curve and everything, but the tip of the wire is the one which can even cause perforations because it's a pretty stiff wire. So aortography. So when we do these, so I'm only talking about Medtronic because that's the only valve we have available right now. So one thing that we always do an aortogram with the pigtail in the right coronary cusp, and we try to delineate all the three cusps in a way that the lower part of these three sinuses is aligned in one line. That's the annular view. And then obviously the newer concept is this cusp overlap view. Will show a slide accordingly. But for the purpose of the procedure, we always push the pigtail in the non-coronary cusp. So here's this patient where they have got the valve up. The pigtail is still in the right coronary cusp. They forgot to put it in the non-coronary cusp, which should be here. So they've started doing the valve. So halfway during the valve deployment, once the valve has deployed a good bit, the pigtail has even moved higher. So at this point, this is the point when they're trying to make a final judgment call of whether they're going to deploy it or they're going to recapture it. So they decided based on just this view that it looks pretty deep, and they deployed it. So because of this one mistake, they deployed pretty high, and you can see all this paravalvular leak because it's actually a supraannular deployment. So again, we need to be cognizant of the fact that these procedural steps all have to be followed for us to avoid these complications. In interest of time, go quickly. So again, when you're deploying, you have to make a decision about deployment or recapture based on what you see, but for that your pigtail has to be accurate. Your parallax has to be removed. There is always this issue of dense calcium and what do you do with it. And then you have this issue of valve pop-outs. So just a couple of things. So cusp overlap view is a lot more in fashion now. When we were doing it, like at Sinai, we were in the middle of checking out whether it's to be done or not. And in the initial phases, we had a lot of pop-outs. And the reason was that we were only looking in the cusp overlap view. And now the recommended and accepted technique is that you go up to the point of no deployment, that is 2/3 deployment, and at that point you go into your LAO view where you have all the three sinuses, and then you check there as well before you're deploying it, and that has increased the success rate. The benefit of doing this is that the pacemaker rate with core valve was up to 8 to 10% in the initial trials. It has come down to 1% because you're deploying higher now. Then we have the issue of commissural alignment, and what we have done is, so there is a flush port outside, and what it does, it's in the same line as the C-tab, and then the hat marker is around 90 degrees away from it. And so this technique has been evolved because with the more low-risk patients that we are enrolling, we are doing younger patients. And what that means is these patients who are going to live 10, 20 years after this valve, we might need to go in and intervene on their coronaries. So if you have seen the Medtronic valve, it's like a mesh. So you can't really predict where the commissural lines are, where the sutures are, and how will you be able to go back through them into the coronaries. So what this does is, so it's a gross method. There is data behind it that if you do it, you are 80% sure to miss the ostium of the left coronary artery from the you can avoid the alignment of a commissural line in front of it. So there's a C-tab. We try to align it outside or in front, And with that, if we do that, the CT-based data shows that there is around 75 to 80% probability that we will be able to avoid the osteoma of the left coronary artery from being impinged behind it. This issue does not have any acute consequences. It's just for long-term management, because with 60-year-olds that are getting TAVRs, we need to think about their second valve as well. And if the first valve goes in aligned with this sort of alignment, the issue of deploying a second TAVR inside them will be much easier, because the coronaries will be clean and we will not be compromising the flow to the coronaries. So deployment wise, I have time. I'll just do this last thing. So initial deployment, so what we do, so if you look at it, now that we have seen all that data, so this CTAV, which is the dark marker here, it's in the outer curve. So this procedure was done with commissural alignment. This is outside, so this is a good position to start off. We start initially, pigtail is in the non-coronary cusp. We are injecting to make sure our position is great. So we come up to the point of no deployment, which is almost 2/3 deployment. So at this point, the leaflets are open. And once the leaflets are open, you do not have an obstructed aortic valve. So until the leaflets open, which is 2/3 deployment, you're actually occluding the aortic orifice. So at that is not the time to be discussing amongst yourself. You go quickly to the point of no return, and then at that point you check once you have blood flow, and this is the perfect time because there is no hemodynamic compromise. But what you see here is a lot of paravalvular leak. So this valve, by its in terms of permissions, we have the permission to recapture and redeploy for 3 times. So this was recaptured. So this second time it was deployed a bit higher. The third deployment was perfect. This is it. So we will go into that procedural technique sometime else, because we have no time for it. But this is a pretty good deployment, and there's no real paravalvular leak in this case. So under expanded valve. So this is if somebody has severe calcium on the aortic valve and you try to deploy a valve without actually pre-dilating, you'll end up with a valve which is similar to this. So really grossly under expanded valve, and if you actually deploy it, it might actually just pop out. So in this case, operators did the right thing. They pulled everything out. They pre-dilated the valve with a balloon, and then they were able to deploy it, and you can see it's opening up pretty nicely. And then last thing, valve pop out. So again, if you deploy it too high, or if you do something like this. So if you see this nose cone coming out and it hooks onto the valve and goes out. So that's something which happened pretty commonly in the initial days, because people thought we have done a pretty good valve, and they would ignore this step where the actual nose cone is coming out, and it actually hooks onto this big C-tab, and it actually takes the entire valve out with it. So obviously something like this happens, you have to hold this valve with a snare, because the subsequent valve which goes in through it is going to push it, and it's going to try to bring it down. So going up is not an issue, but coming down is an issue, because this part of the valve is much wider than the narrower part. So this part of the valve going down can actually rupture the aorta. So you have to be very careful that this does not go back down. It will only go back up to the point where it gets stuck in the aorta. So at the point of any resistance, it will stop. So you are safe up till here, but you need to keep the valve in this position while you're going it down. And the other thing you need to check is that these leaflets are not in front of the origin of the left subclavian, right subclavian. So this is a valve being deployed, and the deployment was pretty good. So again, we have to make sure we are deploying under fluoro, making sure we are following all the rules, and then managing PVL. We can always. So this is an interesting case. This valve was deployed pretty deep. So this is the line of your sinuses. It's deployed. So one of these diamonds is around 8 millimeters. This is the newer valve. So it's deployed around 12 millimeters below the actual line. So it's pretty deep. So what they've done is they've put in a second valve which starts much higher, and they're deploying it, and after that the paravalvular leak has improved. And then in terms of vascular closure, I think the safest and the easiest thing to do is that if you have a safety wire, there is bleed around it, one second, around your access site after you've done your per close sutures. Then what you can do is you can put a 6 or 7 or balloon, depending on what the size was on the CT. Go up to minimal inflation pressure. Don't go up really high, because then you can cause a dissection. And then on top of it, you manually press and you give some protamine and usually get away with it. Perfect. I think we'll stop here. Yeah, thank you.